So good afternoon, and thank you for being today with us to the introduction to this relapsing polychondritis seminar, or because this seminar is dedicated almost for patients. The subtitle is How to Explain Relapsing Polychondritis to My Family and Friends. My name is Simona Rednik. I'm coming from a town which is called Cluj, which is in Romania, in Transylvania. And I'm one of the two coordinators of the Relapsing Polychondritis working group in the European Rare Disease Network, which is called ReCONNET. Today, webinar was prepared and will be presented by Oliver Sander. Oliver Sander is a rheumatologist in Düsseldorf, Germany. His current position is senior consultant. He's also the head of the outpatient department of Düsseldorf Polyclinic. He's the coordinator of the student education for musculoskeletal disease in Heinrich-Heine University. And he's also the coordinator of the local board for rare diseases. That's why he's interested in relapsing polychondritis. And he's one of the most active persons in the relapsing polychondritis group in our group. He prepared this presentation, which I already said is dedicated almost to patients, together with our two EPACs, with Lisa Matthews and with Camelia Buksha, which are here with us. And also at the end of his presentation, Lisa will be present and will also comment the patient perspective. Of course, relapsing polychondritis is a rare disease. It is unknown to the general population and also to many doctors. And it's not only about years. Of course, years are in the center of this disease, but it's not only about years. And patients could go to rheumatologists, but also to dermatologists or to general physicians or to ENT doctors. So sometimes their steps are not so easy, and that's why we have to discuss a little bit those things. Of course, the webinar will be recorded and it will be published on the ReCONNET website and also on our YouTube channel. If you want to put questions, please write them on the question and answer section or use the chat, and we will try to answer to all your questions at the end. And at the end of the presentation, we will have a short discussion. So thank you again. And I'll give the word to Oliver. Please, Oliver.
Yeah, thank you, Simona. Hello, everybody. I send greetings from Düsseldorf, Germany, and now I start to share the screen and want to talk about introduction to relapsing polychondritis, just to explain the disease and how to explain relapsing polychondritis to my family and friends, but also probably to family doctor or any other doctor, and show you the main facts which are relevant for you who are interested in that disease. So I could only present the physician's perspective, even when I think of how to look with patient's eye. And even though we discussed the items before, if you don't understand anything, please ask and we could discuss it later. The webinar aims to explain the symptoms and consequences of relapsing polychondritis, show different causes and causes of the disease, and give possibilities of treatment for the disease, improve contribution of the affected patient and the relatives to a better course of the disease, and for future treatment and diagnostics. So, definition of the disease: relapsing polychondritis, and this is a definition for the physicians, so you don't have to understand everything, is a rare, so it's very rare, and out of the rare diseases in ERN ReCONNET, it's rarest disease. So you could expect that 9 people out of 1 million have relapsing polychondritis, and you have a rate of new diseases, which is about 1 in 1.4 million people a year. So in a very big city, only one gets a disease new in 1 year. So it's very, very rare. It's clinically heterogeneous, so there are many different types the disease might present, and it is multisystemic and inflammatory. So you have inflammation systemically or locally, for instance, at the ears, and it is characterized by inflammation mainly of the cartilage, and there are many places in your body where you can find cartilage, and also proteoglycan-rich structures like connective tissue. That's the reason relapsing polychondritis is in the connective tissue group of the rare diseases. The inflammation might lead to cartilage damage along with joint, because joints contain a lot of cartilage, ocular and cardiovascular involvement. So there are many ways to describe the disease for physicians. Usually you have a classification of disease and give them numbers. You have new classification numbers, and in the register for rare diseases, the OrphaNet, it has also numbers. So we could give it a name and we could give it a number to find it when we look for it in any registers. So now I explain the definition of the disease for you as a patient. So it's a very rare disease, and you have to see more than 100,000 people to meet one patient who suffers from that disease. So it's really hard to meet any other person by chance who has that disease. And it's really hard that anyone you knows a person who has a disease. And you have to see more than 1.4 million people a year to meet one patient with a new disease. So also your doctor and even your specialist does not see a new patient every year. Every patient has a different course of the disease. So it's really hard to find 2 patients who have the same course of the disease. And the disease results in pain and inflammation in regions with cartilage and proteoglycan-rich structures of the connective tissue. These are joints, ears, eyes, nose, lung, heart, vessels, and some other places. And result of inflammation is pain. So, for instance, which is typical for the disease, you have an acute painful red ear or an acute arthritis of one or several joints. The disease on long term may cause damage of the affected structures, here mainly the cartilage, that might lead to organ failure. Concerning the ears, it might be a floppy ear or a cauliflower ear. Concerning the joints, it might result in osteoarthritis. The disease might be, but rarely, life-threatening, and very rarely cause life-threatening symptoms, especially of the upper and lower airways with the airway stenosis. So you might find very rarely patients with relapsing polychondritis, for instance, at the intensive care unit. Usually it's painful, but in most cases, it is not life-threatening, but it might be. So definition of the disease and occurrence. we don't know the real cause of relapsing polychondritis. So we have some ideas, we have proven other ideas, but we have no real consequent cause of relapsing polychondritis. We have some features who describe the disease, and they are so-called autoinflammation, autoimmunity, and granuloma formulations. It's different ways your immune system might react to infections or to tumor, and in relapsing polychondritis, this immune system does not work properly and acts to your cartilage and your proteoglycan-rich structures. The risk of inheritance is not proved yet. There are very, very few, but some familiar cases reported, but usually this is very, very rare that you have two persons in the same family. We have different types of relapsing polychondritis. So we have a primary disease where you have relapsing polychondritis, but no other disease. And you might have relapsing polychondritis as a secondary disease with an underlying other autoimmune disease. So you might have rheumatoid arthritis, systemic lupus erythematosus, Sjögren's syndrome, Hashimoto thyroiditis, and have a secondary relapsing polychondritis. Thus, it's important, if you have symptoms of a relapsing polychondritis, at least once, there should be looked at other rheumatic diseases and look if there's an overlap with other diseases. You could also have relapsing polychondritis secondary to hematologic diseases like Vexer syndrome, lymphoma, so mainly malignant hematologic diseases might have their first presentation as relapsing polychondritis. So it's important to have a look on that. And you have clinical overlapping features with vasculitis. You have vascular inflammation like so-called granulomatosis with polyangiitis or Behçet disease, which might make the same symptoms. And it's hard to decide at the first view it's relapsing polychondritis or it's vasculitis like Behçet's or granulomatosis with polyangiitis. Now I come to the symptoms and the reported frequency from registers. Most of the symptoms, and most people have symptoms like an ear chondritis, which is abbreviated as a red ear, red painful ear, an acute red painful ear, lasting some days and which might give relief and disappear after some days. More than 90% of the patients with relapsing polychondritis have that, but 10% or nearly 10% don't have the ear chondritis. And usually they first go to the ENT specialist and they have to think of it. You often, or patients often have musculoskeletal symptoms, more than 50% to 75%, usually joint pain, arthritis, and then they usually go to the rheumatologist first. Many patients, more than half, have a chondritis of nose or upper airways, and then go to the ENT specialist too, or have an inflammation of the eye, and then they go to their ophthalmologist, and he has to think of the disease or ask for other things. So those are the most common regions which are affected by relapsing polychondritis in at least every second to nearly 90%. The other causes are much rarer, like chondritis of lower airways. 1/3 of the patients have it, and they usually go to the pulmonologist, or they feel a common sickness like a flu, which does not stop. This is in every 5th of the patients, and it represents a systemic disease. And they usually go to the family doctor and say, oh, I have a flu, but I don't get rid of it. Some have an inflammation of vessels and heart valves, and they go to the cardiologist, or more rare, they have skin inflammation and go to the dermatologist. One of the lower airways and upper airways symptoms, you don't think that it comes from there, might be breathlessness on exercise, which is one of the symptoms, and you don't think, oh, it comes from my upper airways, but it might be more evident if you have a hoarse voice or a stridor when you breathe. If you have the symptoms, it's hard to find the right diagnosis because it's so rare. There's no single blood or imaging test that can be used to diagnose relapsing polychondritis. Many diseases we have blood tests which help us, but in relapsing polychondritis, you don't have the possibility to say, oh, I want to make a blood test and know if I have the disease or not. Diagnosis is based upon a combination of clinical presentations. So it's like a puzzle. If you have this auricular chondritis, the inflammation of the ear, inflammation of the joint, of the nose, of the eye, of the respiratory tract, or an audiovestibular damage. And if you have at least 4 of them, so more than 3 of them, then it is probable that you have relapsing polychondritis, primary or secondary. So you have to collect those symptoms and present them when you go to your doctor. Usually you make a retrospective diagnosis because it's rare that you have all the symptoms at the same point in time. So collect them if you are requesting for the disease, acute symptoms, remitting symptoms, flare and relapse. Make a good documentation, take pictures with your smartphone, and important to the doctors, exclude other causes because there are many causes for polyarthritis. There are many causes for red ears, and you have to exclude the other causes. And if you excluded this and you don't have any other explanation, then they are relevant to find the diagnosis. So as this is the most common finding, I should show one clinical slide with the red ear. It's red, it's swollen, it's sparing the lobule because there is no cartilage in the lobule. It's very, very painful, and it lasts for at least 2 days, but usually resolves later. If you have the right diagnosis, it's hard to find the right treatment. There is no established standard therapy for relapsing polychondritis. Treatment is based upon symptomatic therapy, like treatment of pain or inflammation, prevention of new flares, both or even no treatment. Healing is not to be expected in relapsing polychondritis. The natural course of the disease allows flares, remissions, relapse, chronic inflammation, and damage, but you must not get damage, you must not get chronic inflammation. You might have remission and no relapse and further course. So 10% of our patients we oversee have a benign course with only few flares. Usually they don't need any preventional treatment and only need a treatment when they have a flare. Most of the patients have a moderate severity, and only few patients have a chronic inflammation with damage and a refractory disease. So this is rare in the rare disease. So we have no established standard therapy. We have symptomatic therapy, and we could use common non-steroidal anti-inflammatory drugs for inflammation and pain, like ibuprofen or diclofenac. If that is not enough, we could use steroid like cortisone, and for joint pain, for instance, or breast problems, we could use physiotherapy. And for prevention, if you have frequent relapses, we could use some herbs like colchicine, which is an old but really effective herb which you could use for herbal therapy. We could use chemical immunomodulating drugs like dapsone or methotrexate, drugs we know from other skin diseases or from rheumatic diseases. And in severe cases, we could even use genetically engineered drugs, so-called biologicals, which are antibodies to inflammatory proteins who could deal with your disease, like anti-TNF or anti-IL-1. Most important thing is measure disease activity to have an idea who has to be treated, measure damage just to know how much damage does the disease make in your course, so you don't treat with a drug which makes more damage than the disease itself. So be aware of high dose steroids on long term. You prevent damage of the disease, but you will get damage of the drugs. Measure patient relevant outcome, because you are the target and your good outcome and your targets are the main topic of treatment of the doctor. So you are that who gives the route. One might be fatigue, and we will care more on fatigue in future. So your contribution to a better course of your disease, trust in your doctor, even if he or she has misdiagnosed the disease in front, because most of the doctors don't have an idea on relapsing polychondritis and misdiagnose it first. Ask your doctor to improve his or her knowledge in the disease by using webinars or publications. Improve and communicate your knowledge in the disease and therapy. So you are your own doctor to some extent. Make an agreement with your doctor on therapy, therapeutic target, and outcome measurement, so you both go the same way. If you don't find your way, ask a specialist, like in the ERN ReCONNET. Be adherent to therapy and controls, because only if you take the drugs and control effect, you might get help, and reduce additional risk on your life quality, like smoking, obesity, sedentary lifestyle, or poor diet. That are major things you could do and improve your life expectancy. But you could contribute to a better course of the disease in general and in future and for your other patient. Ask your doctor to improve his knowledge, like webinars. Improve and communicate your knowledge. Help to improve and communicate knowledge to medical students and other family doctors and specialists. So participate in webinars, participate in patient support and advocate groups, participate in register, and perhaps participate in clinical trials if they are offered to you. And your perspective as a closure, as a patient with relapsing polychondritis, you have to know you are very special, almost unique. Let the others know. Share your story, share your data, improve your knowledge, the knowledge of your practitioners, and the knowledge of everyone involved, like your family, your relatives, and anyone else. But you have to know you are not alone. Even if it's rare, you are not alone. Start and continue networking, for instance, in the patient advocate groups, with healthcare professionals you trust and who will try to understand the disease and its severity and improve it in your interest, with relatives and friends who accept, accompany, and support you, with other patients who share your illness and have similar experiences as you do to comparable illnesses. Thank you very much.
Thank you so much, Oliver. It was great for me to listen to you. There are already some questions which I had in the chat, but now I'll. So one of the question was, you touched this problem, but maybe we can discuss a little bit later. How often is relapsing polychondritis disabling, and to what extent can it disable patient? If we have statistic, of course, disability is very different, that it depends on many organs, but maybe you can comment on this.
Yeah, one disabling part is the ears. If you work with headphones or so, you are disabled when you have the inflammation of the ears. When you have shortness of breath, stridor, or problems with your voice, probably you have disabling in sports or working as a teacher if you could not speak loud, or working as a singer or as an actor. And if you have joint problems, that might affect your ability to work hard walking or carrying things or so. So it just depends on which sites are affected, but there are local sites which are affected, like the ears or the joints, and there are systemic sites affected, like shortness of breath, cardiac involvement, which reduces your overall capacity to work or gives you a need of rest. And as a third part, you might be disabled by drugs you take, like high dose steroids, which might disable you. So if you take drugs, you might be disabled by them. So you have no more symptoms of the disease, but perhaps some disabling by the drugs. So these are the major points. But every individual has different parts, so it has to be checked individually and could not be generalized for the disease.
And as you already said, the majority of the cases are not severe generally. So the moderate forms is the majority of the cases. A very few of them are severe, and disability depends a lot on the organ which is involved, can be very different. Please, Lisa, your comment will be great.
I was just going to say, in the patient group, I find that the majority of us have had to adapt our life in some way. Either give up I've had to give up my work because I did interviewing, so I can't use my voice for very long. There's a lot of people that go part-time, they claim disability benefits, but it's not everybody. People do seem to soldier on, and then eventually they do have to adapt in some way.
Another question, Oliver, was how do you know if you have inflammation of vessels, of heart valves?
So how to test if you have the inflammation of vessels?
How do you know? Yeah.
Yes. If you have larger vessels, you could see the inflammation using imaging technologies like ultrasound or computed tomography or magnetic resonance tomography or positron emission tomography. So you have different ways of making an image of larger vessels and show that you have a vessel effect. You could not distinguish vessel involvement from other diseases with large vessel involvements. So you have to do other tests to confirm that by autoantibodies or so. But you could find vessel inflammation with those tests, especially with imaging tests.
Hey, another. It's not really a question. She's asking about our thoughts. Patient, she had symptoms in childhood, but ended up with lymphoma in her 30s, which might indicated that the relapsing polychondritis was associated, was primary to lymphoma. Which is your opinion? You already talked about overlapping with other diseases.
I think there might be two ways. One way is we know in common that rheumatic diseases with increased inflammation result in a higher lymphoma risk. So it might be that you had the relapsing polychondritis and then developed a lymphoma secondary to your chronic inflammation, which started very, very early in your life, or you might have had underlying lymphoma, which was not detected, first had symptoms of relapsing polychondritis, and after some years, lymphoma has a manifestation and you see it. So I think there are both possibilities, and it depends just on the time you had the symptoms. If you have 30 years of relapsing polychondritis and then you see a lymphoma, it would be more likely to be secondary to chronic inflammation or developed by chance. If you have symptoms of relapsing polychondritis for 2 years and then you see a lymphoma, it might be secondary to lymphoma.
That's why clustering and disease subgroups are very important, because it seems that there are some some clinical features of relapsing polychondritis which suggest more overlapping with myelodysplastic disease, like the VEXA syndrome, which is recently described. But also there are manifestations which are never associated with a myelodysplastic syndrome. There are many questions. There is another question about the histamine, if there is any correlation with the histamine levels in relation to relapsing polychondritis. Since I know, no, but Oliver, you have another.
I haven't heard anything of that. There is local histamine in inflammation, but it's not a systemic histamine overload which results in.
Of course, no. So doesn't seem to be important. Another interesting question: have you seen any flare correlation to traumatic triggers like surgery? I've
seen some. We know from surgery of the joints that they might have inflammation, and this is what I discussed, an autoinflammatory part of the disease. So triggers like infection or trauma might cause inflammation, which results in an aggravation of the symptoms. And I have experience with some patients who had surgery and worsening thereafter. So be very careful with that. And we know it from the airways too. If you have someone who is not so experienced in bronchoscopy and he makes a bronchoscopy in a more traumatic way, he might give you as a patient more danger and side effects than benefit. So be careful and just try to go to people who know what they do with any intervention.
Lisa or Camelia, do you have experience? Do you have flares after trauma or surgery?
No, not from my side, no.
I would say that mine probably started after a virus, a chest infection, and then a stressful thing in my life triggered it, and the combination, I think that, and I see a lot of group members that there's been a trauma or a stress.
Yeah, it was exactly the same for me. Trauma together with inflammation, with infection, sorry.
Another question is if it's common to see nerve involvement in relapsing polychondritis.
I haven't understood. To what involvement?
Nerves.
Nerves. It's much less common than in other diseases like vasculitis or lupus. They have much more common because nerves don't have this this tissue which is affected. It might be secondary due to the arthritis or so, but not primary. It's much less common.
Okay, so I will check for other questions, but maybe we can discuss a little bit with our patients present, with our EPAGs. Can we ask you something, Lisa? Can you ask you which was?
What did your doctors tell you about their knowledge on relapsing polychondritis? Do they respond open to you and say, "Oh, I have never heard of it," or what do they tell you?
In my experience, it was my GP that mentioned RP to me. It took me 7 years to get a diagnosis. And eventually it was my GP that happened to have come across an article from Professor De Cruz and said, "I think this is you." And we read it, and then he put me in the right direction. But even then, local rheumatologists still refused to diagnose RP because I didn't have the classic ears flaring all the time. Mine was purely airway. Until 1 year, my ears flared up because I had a relationship breakdown. And even then, they said no, because you've only got 2 symptoms, until I collapsed at work because I couldn't breathe. So in my experience, I was very lucky to click on a GP that happened to read it one day. But even then, finding the specialist that can treat, this was 15 years ago almost, and I think things have improved. But in my group now, I still hear patients, even if they've gone through our website, they've got some information, they've gone through several bouts of antibiotics for ears flares, it's hard for that to get across. This could be RP. So it's very sporadic, I'd say, and I don't know what it's like in the rest of Europe, but in the UK it's getting better. But certainly in my day, it was a case of this is too rare, you can't have it, you're too young, no way. And, you know, I was even told to see a psychologist at one point, and I was closed on my own airway. So, yeah, but I think hopefully things have changed, getting better.
It's rare. It's also very polymorphous. So some patients manifest in a way, others in others, that there are different specialists which can see the disease or the patient addressed to different specialists. So this is a problem. And it's also intermittent, like the name is saying, that's relapsing, so it's coming and going. So, and one of the suggestion is always take pictures of your nose, of your ears, or if you have, because it will be gone till you will arrive to a physician. And it's important to have some photos with you.
And I think one important thing Lisa said on her story is that her family doctor reminded an article he had read. So communicate.
Yeah.
Just use every time point to communicate your disease, because you only as a doctor remember these rare things if you have heard of it, read of it, seen a patient with it. So try to communicate it with everybody, just to keep them aware of this very rare disease. And for us is to write on the disease, make webinars, to have a high grade of communication, which helps to shorten the time to the diagnosis.
Okay. Other questions?
I think there's a question in the chat. In your experience, what medication works best for patients for longer periods of remission is a question. And I think therapy is patient depending and depends on the disease, the inflammation of the patient. So we have patients who have long periods of remission spontaneously and don't need any drug. If they have mild disease, you could try colchicine or dapsone. If they have more inflammation and especially joint affection, you might use methotrexate, which is a good drug we know from rheumatology, which is easy to take and has few side effects. But if you have a highly active disease with high grade of inflammation, the best things to my experience are the more modern drug like biologicals or cytostatics like cyclophosphamide or so, depending on availability and the course of the disease, of course.
So again, there is no one drug to use. So there are several and different drugs, and it's tailored to patients and to manifestation and to organ involvement and to severity also. There is another question about diet, if diet is important for the treatment of the disease. Since I know there are no clear data about diet. Oliver,
it's important not to have too much overweight, because this affects your joints and you might get minor traumas to your cartilage of your knees and your hips if you're too heavy, too weighted. And if you take medication like steroids, it is good not to take too much sugar and fatty acids. And we know from other inflammatory diseases where we have more data like rheumatoid arthritis or lupus, that it's good to have a cost which has less meat and a little bit more vegetables and some fish, just to prevent some inflammation. But the effect of diet is not that much that you could really change your disease or be rid of medication. So it's only a small addition to the other forms. Most important things is no smoking, healthy diet, just do some sport, but not too extensive. Those are the major things you could do.
Okay, there is another question about what causes exhaustion, or I think the question is fatigue. What causes fatigue? Fatigue is a very interesting symptom, and it's appear in all autoimmune diseases. In relapsing polychondritis also, it's much more related to inflammation. But there are maybe many things which can cause it. It's complicated and it's not a very well-known symptom, but there it's so the resolve of it, it's together with treating the inflammation generally and the disease. And also another question about which doctor should I see for shortness of breath. So as Oliver tell you, it can be coming from the upper airways. So maybe you need to see a otorhinolaryngologist or a pulmonologist. But generally, the rheumatologists are knowing how to do and to decide where you have to go.
Probably even the cardiologist, because it might comes from your heart valve. So first perhaps go to your family doctor, or if you have an appointment in near future, go to your rheumatologist or a specialist in internal medicine, and they will see where it might go. Yeah.
Okay, another question is how to assess the level of inflammation in relapsing polychondritis patients. Yes, Oliver, please.
It's difficult because it depends on the organ involved. You could measure some systemic inflammation with CRP levels or ESR levels, so with blood tests in some patients, but at least 1/3 of our patients never had any lab abnormalities. So in those patients, you could not test it with blood tests. So only in those from whom you know that they react with the blood levels. If you have flares of the ears, you could count the amount of flares, the time lapse between the flares. And if you have vessel involvement, you, for instance, could make a new image and look whether you have more damage, if you have more wall thickness, or if you have any damage which might be a consequence of inflammation. But it's really hard to find one value which represents activity of the disease. And one of our things we have to do in future, and we are working on, is to find activity markers for the disease, which make a better picture on disease activity and make it comparable. This is where we are all working on in the group.
So there is another question about, is there any good way to repair your nose from nose damage without causing flares? I can comment. So yes, of course, if there is no an active disease, we can try to repair. So there are plastician surgery which can do it. But the most important thing is that the disease have to be not active.
And perhaps to prevent reactivation during surgery, to give perhaps some drugs during surgery, even if your disease is not active, to prevent reactivation. But this you have to discuss with your rheumatologist or your specialist and the surgeon who works on it. So it's only co-work and possible by co-work.
Yes. There is another question which is coming for the second time. If relapsing polychondritis can cause high blood pressure. High blood pressure is generally related to renal involvement. Renal involvement is very rare in relapsing polychondritis. It can happen, but I think it's happening for less than 10% of the patients, so it's not very common. But high blood pressure is a common comorbidity. It can be really separate, so not with the disease.
Especially on steroids. So if you take too many steroids, too long steroids treatment,
or drug related,
cause,
yes. Okay. So it was interesting, and people put many questions, and we like to talk with you. If there are no other questions, maybe a comment at the end, Lisa.
There was a couple of more actually we missed. There was one question that I saw at the beginning. Oliver's calling it a disease, and often it's referred to as a condition, and this might be country dependent. I'm not sure. So I'm wondering if one of you could clarify why there would be discrepancies, what would be the difference?
So the condition means that it is a sum of symptoms which must not be a disease, but might be a group of symptoms related to another disease. So if you have, for instance, Vexus and you have relapsing polychondritis, it's not a second disease, but it's a condition. But if you have primary, so-called primary relapsing polychondritis with no other underlying or secondary problems, you could name it disease. Perhaps that's the explanation of the two different types of wordings.
Thank you.
So it's a disease, of course, because have symptoms, have diagnosis, has classification criteria, has a treatment. So it's a disease. Of course, maybe. Okay. Amelia, if you want to comment something.
No, I think not more. Thank you for this very comprehensive presentation. I would maybe only emphasize that maybe each patient would better take very good care of themselves in terms of observing their bodies and knowing their bodies, and just play along and just adjust what you can. For me, for example, it worked very well, the physiotherapy, meaning some kind of exercise, but not too much. And the fatigue it improved a lot with the exercise, but not a lot again. So yeah, there are a lot of things that we can do actually as patients for ourselves. And yeah, that's about it, I think.
Oliver?
I think we have several small steps to go, and several small steps we could go with everyone and for everyone. But I don't expect one big deal which stops the disease in the next future. So we all have to work together. We all have to do the steps together, and only together we could go forward in small steps. But I think we have reached a lot in the last 20 years, and I'm really sure that we reach much more in the next 10 years.
Okay, so thank you to all of you. Thank you, Oliver. Thank you so much for preparing this webinar. Thank you, Lisa, and thank you, Camelia, to give the input of the patient. Thank you to you, all the audience who was so active and put so many questions. I want to remember the things which Oliver already said, that of course it's a rare disease, but it's all of you are very precious and important for us. Maybe some doctors don't know so many things about the disease. You will try to find the way to the doctors who know and who want to learn about it. And many things are happening in this sector, speaking about science, speaking about drugs, speaking about registers. So I think it's a good moment for relapsing polychondritis, and things, as Lisa already said, are changing, and people, doctors and patients and general population know more about this disease. So thank you again. You can contact us and to ask other questions if you need and if you want. The ReCONNET network is for such rare diseases, and you can contact us in any way. Thank you so much, and goodbye. Have a nice evening.
Thank you.
Thank you, Simona, for moderating it and making it all round session. Thank you very much, Simona.
Thank you.
Thank you.